Petros, as a community oncologist, we're often relying on NCCN guidelines. This is approved, this is part of NCCN guidelines now. Where does it sit in terms of the recommendation as part of NCCN guideline?
I think based on what we discussed, this has level 1 evidence. So if you have a patient in the clinic who is fit for cisplatin, we can discuss about the creatinine clearance threshold. It can vary depending on who you talk to. For example, in that trial went down to 40 cc per minute or higher. Some other folks may go to 50 or higher depending on your threshold. But if you think the patient is eligible for cisplatin and has no contraindication to get the checkpoint inhibitor, personally I think that the NIAGARA regimen has level 1 evidence, and I think it should be considered in patients, again, who can tolerate this treatment. One side note, personally speaking, Josh and me have talked about that, I tend to use ddMVAC with growth factor support in clinical practice. Overall, compared to GemCis, there is no strong data comparing the two that shows significant evidence of benefit to ddMVAC. But if you put everything together, to me, it looks compelling. So if I had the chance, I would use ddMVAC with growth factor plus Durvalumab, if insurance can approve that. And there is some phase 2 data supporting that approach. But based on, from a purist approach, based on the NIAGARA regimen, GemCis Durvalumab is a standard of care with level 1 evidence based on the NIAGARA trial.